Um, and I've just started being recorded, so that all my best jokes have been missed already. I'm going to say got it. Right, so this is your syllabus. I'm not expecting you to read it, but I am going to summarize it for you. This is the old syllabus. I mean, it's the old curriculum. And let me just click on that. So they basically can be summarized in terms of the topics that the curriculum, the Royal College want you to know about, can be summarized into neonates, into the sick child, basically, and then some random stuff, which is just relevant to pediatrics, and I'll touch on most of these. And then there's this sort of thing in the middle, which basically talks about anything to do with pediatric anesthesia, and it's a bit ridiculous, but I think probably quite a good way of thinking about it for the exam is looking at what has come up in the past, and there is a general consistency to topics that are being asked at exam questions. The chances are you will get something related to a pediatric case in your final, so expect it. But most of the topics come up again and again. So that is a summary of the topics that have come up in the last 10 years. And there's a high chance that they will just be revamped in slightly different wording. So at the very least, I would have some idea about them. And we're going to go through quite a lot of them. I'm not going to go through the anatomy bit of it because I mean, basically, I don't really know it. But I am going to talk about a few of the other cases, and we're going to start off by talking about neonates. A few example questions. So this is a question from 2017. A 5-year-old boy presents for a laryngotomy and grommet insertion as a day case. During your preoperative assessment, you notice that he has nasal discharge. List the features and examination that would potentially cause an increased risk of airway complications. Why would it be inappropriate to cancel the operation? And social factors that would prevent this child from being treated as a day case. So if you've not seen this question before, we're going to think about a few of those things during the talk. This is really just to get you into the mood of what type of thing you might be asked to answer in an exam. You're called to the emergency department to see a 2-year-old who presents with a 4-hour history of a high temperature and drowsiness. They've got a prolonged capillary refill time and a non-blanching rash, and a diagnosis of meningococcal sepsis is made. Then you get asked a few generic questions about the normal physiology for a child of that age, and then the goals of resuscitation and the fact that they then don't respond, and you're basically being asked to manage a sick child. So there is a lot of consistency with the curriculum, and what I'm going to do is to try and address these 4 main topics during the next 40 minutes. So this is my entire pediatric career condensed into 40 minutes, and I hope I can stretch it out to that long. Neonates. I'm just going to talk a little bit about what the general approach to anesthetizing a neonate is if you've not done it. And if you have to talk about it in your viva bit, then you want to sound confident that you know some of these principles. So a neonate is a baby that is under 44 weeks post-conceptual age. The importance of that is that includes premature babies who are 3 or 4 months old, but haven't yet reached 44 weeks PC, post-conceptual age. So the vast majority of neonates will be anesthetized with a gas induction on oxygen and sevoflurane. They will be intubated, and generally speaking, we use uncuffed endotracheal tubes. We ventilate them throughout. We don't generally have them on pressure support, and we don't let them breathe spontaneously because of the resistance in the tubing. They are at risk of hypoglycemia, and therefore glucose is generally added to maintenance fluids, and you need to check the blood glucose regularly. And they're at high risk of hypothermia. So you do everything you can to warm them, and you measure their temperature, and they are, for exam purposes, in reality as well, they are at risk of post-op apneas. We do use opiates. It's perfectly safe to use opiates, but if they are the younger they are, the higher chance they are of having a significant post-op apnea. So we think about regional anesthesia options with a general anesthetic almost exclusively, and they should have apnea monitoring post-operatively. So that's the general principle. If you get asked, how do you anesthetize this, whatever, neonate, it's those are the sort of key things to try and bring out, and you'll sound confident that you've done it. I think it's unlikely you'll be asked about this in a written exam, but you might be. Premature babies are another topic that might come up, and I think you should be aware of a couple of things about them. So they are they're babies that are born less than 37 weeks gestation. There's a few risk factors to be aware of. And it's basically a very young or a very old mother. 40 is not old, by the way, but as far as maternal age for prematurity, it is. Diabetic, preeclamptic, smoking, mum. So sort of think of a sort of diabetic, unhealthy mother that you sort of wouldn't want to have to come across on labour ward, and you've sort of got the idea. And their previous premature babies is also a risk factor. There's also placental risk factors, so placental and baby risk factors, so intrauterine growth retardation, congenital abnormalities have a high risk of prematurity, abruption, and chorioamnionitis infection also does. There's a risk of lots of different things that can then happen to premature babies. And I don't think you need to know sort of an exhaustive list, but probably the key things are to understand that they have worse lungs, so they're at risk of having chronic lung disease, and often they are oxygen dependent for some time, many months after they're born. They have a higher risk of some cardiac anomalies, particularly a PDA. They have an increased risk of hypoglycemia even compared to normal babies. And then there's lots of other things that can happen, are often why they come to hospital, why they come to theatres. So neck is one and an IVH is another. That's often reasons why we need to operate on or need to anaesthetize them for their operations. I'm now just going to go through a few basic operations that you might have to be aware of for an exam. And I'm going to start off with a hernia repair. I think you should be aware that there are options for doing a hernia repair without a general anaesthetic under a spinal and sedation. You don't need to understand or be able to explain anything about that, but just be aware of it. In case they say, is there any other way that you could anaesthetize this child? You might want to say that you could do it under a spinal with some sucrose sedation, but in reality, that's fairly uncommon, and it's very uncommon in our centre in Bristol. They can have a caudal with a GA, or they can have a local block with the GA, or they can just have local infiltration from the surgeons and a GA. So on to a few specific topics, and sort of things that have come up, as I say, in previous exam questions, and just things you need to be able to talk about or write about in a final exam. I would normally say this has some sort of interaction normally, but I'd say, what is that? But I'm going to ask you, and you don't have to reply, but I'm hoping that a few of you might recognize that as pyloric stenosis. So that's an X-ray of a baby who's got a thickened pylorus and has got a distended stomach. So pyloric stenosis, it is more common in boys than girls. That's something that can come up in these sort of written exams. It's relatively common, so 1 in 400 live births. Generally presents at a few weeks old with projectile vomiting. It is a medical emergency, not a surgical emergency. Examiners love that that sort of phrase. And you need to know that it is the biochemical abnormality is a hypokalemic, hypochloremic metabolic alkalosis. So it's an alkalosis because you're losing acid from vomiting, and you know that your stomach is acidic, and because you lose potassium, the kidneys basically try to because they lose sodium chloride, I think this is right, that kidneys conserve sodium at the expense of hydrogen. I think the only thing you really need to understand about it is that the kidneys eventually try to conserve sodium, and that you end up with a paradoxical aciduria, whereas you'd expect the urine to be alkalotic, which it is initially, but then it becomes acidotic, and that worsens your alkalosis. So I think you need to know that it is a hypokalemic, hypochloremic, metabolic alkalosis. The treatment for it is a very strict fluid replacement regime, fluid and electrolyte replacement regime over a number of hours, and generally it takes up to 48 hours to correct, but generally you'd be expecting that to correct fairly well by 24 hours. And you want it to be fully corrected and for that to have had time to sort of stabilize before you operate. And the main parameters that you would look for before you operate is a chloride of normal chloride, so above 100, a bicarb of less than 26, and a normal pH prior to surgery. Perioperatively, I'm not going to go through all of the details because I've told you basically what it involves in terms of anesthetizing a neonate, but and it's the same for pyloric stenosis or any other, but the important factors that you might want to mention are that you want to make sure that the stomach is as empty as you can make it. So that's aspirating the NG, and they do this we do this 4-quadrant aspiration. Despite having a higher risk of aspiration or having stuff in the stomach, most of us would still do an inhalation induction with or without cricoid pressure. You intubate and you positive pressure ventilate, as I've said, because they're a neonate. You give analgesia as you sort of see fit, but it's generally just local infiltration and paracetamol, and you extubate the baby awake. And then oral analgesia post-op should be enough, just simple paracetamol, IV or oral should be enough. And feeding generally starts a few hours after the operation. And because they're small, they normally would get apnea monitoring overnight. Again, any ideas what that is? I'm not going to ask for any responses, but that is 2 different conditions, Exomphalos and gastroschisis. So Exomphalos on the left, gastroschisis on the right. Exomphalos has a covering, gastroschisis doesn't. The way I remember it is that the gastro bit of gastroschisis makes me think about the gut, and the gut is fully out in gastroschisis. So gastroschisis is a defect in the abdominal wall. Generally, it's on the right side and there's no covering, and it needs urgent covering and repair, whereas Exomphalos is just a failure of the gut to return into the abdominal cavity, but it is covered by an umbilical cord covering. There is an increased risk of other congenital anomalies with Exomphalos. So we would expect, again, in a centre that does a lot of these, for you to look for them, or for them to be looked for generally by the neonatologist. So doing an echo is the most important thing that we are concerned about. There's a few other things that sort of, you need to be aware of, but I don't think you need to know it for an exam in terms of heat loss and infection. But basically it is simple management in terms of making sure they're warm, covering the defect with a silo. There's this covering called a silo, putting an NG in, starting the child on IV fluids, getting some pre-op investigations done before they come to theatre. And then perioperatively, they're a neonate, so they get an IV or an inhalation induction. Most of us would do an inhalation induction, an endotracheal tube, and positive pressure ventilation, as I've talked about, because they're a neonate. And there's a few other little things, but I don't think you'll be asked about the anaesthetic management for these cases. It's basic neonatal management. We generally will go back to a neonatal unit, intubated. Next neonatal case that you might be asked about is this. Any thoughts before I tell you? That is a coiled NG somewhere up in the high esophagus. And I hope some of you got that right, that it is a TOF, Tracheo-oesophageal fistula, not a tetralogy of Fallow, which is the other TOF. that you might be referred to. So never talk about a TOF, just a TOF. So this is, in American, it's much easier because it's a TEF. It's a tracheoesophageal fistula with an esophageal with an E. So this is, they're relatively uncommon, but they're common if you work in centres like ours, because they all come to us. So about 1 in 4,000 births, I don't think you need to remember that. They're often diagnosed by the presence of polyhydramnios. You might need to know that. There is a high incidence of other anomalies, particularly cardiac anomalies, and it's associated with Bacterl, which has a number of different defects, which you might want another number of different abnormalities you might want to read about. And they generally present problems with feeding, so choking, coughing, cyanotic episodes on feeding, because the food is not able to go down to the stomach and the baby's basically aspirating on it. They then often try to pass an NG tube, but most neonatologists, pediatricians would be fully aware that this is a high risk of being at this stage, that if they're choking like that, that you think about a TOF. And they generally, because of the higher risk of aspiration, they often have this thing called a replogal tube, which allows for irrigation and suction instead of a standard NG tube. This is quite a big deal for an operative thing, so they get a thoracotomy, but despite all of that, they still get an inhalation induction, an ET tube, positive pressure ventilation, because they're a neonate. I don't think you need to know an awful lot about this, but I think you possibly should know that you just have to be particularly careful with your ET tube placement, and they might want to have a bronchoscopy before you do it to see where the defect is in the trachea. There is a risk that when you intubate a child, that most of the ventilation will go down to the stomach, not into the lungs. So you have to be prepared that you might have to pass the tube endobronchial in order to get a one lung ventilation so that you can actually oxygenate the child. But that's probably more detail than you need to know. And then post-op, they definitely remain intubated and go to NICU. Basically what the surgeons will do is to find the fistula, divide it, make sure that there is no remaining fistula between the trachea and the esophagus, and there will be a decision about whether they're going to do a full repair and anastomosis of the esophagus or not, depending on how long bit of esophagus there is to use and so on. But again, you don't need to know a lot about that, but I think you do need to know what it is. Any thoughts on that? Again, you don't have to answer, but that is gut that goes up through a defect in your diaphragm into the chest, otherwise known as a diaphragmatic hernia, or a congenital diaphragmatic hernia, CDH is what it's often referred to. It's usually left-sided, and may be associated with other abnormalities, so you need to look for that, particularly cardiac ones. Children often present with respiratory distress and something called a scaphoid abdomen. I've never seen that, but that's just one of those sort of pathognomonic things that goes along with a CDH. Again, this is not a surgical emergency, but it is often an emergency for NICU, for neonatologists, because they're often very difficult to ventilate. And sometimes they are actually expedited to come to theatre fairly urgently because of that. They're generally intubated before they come down to have their operation. And the anesthetic management, if they're not already intubated, is an inhalation induction, an ET tube, and positive pressure ventilation, because they're a neonate. These are big operations, and we will often put extra lines in and so on. And I don't think you need to talk very much about this in an exam, but again, you might just need to know something about it. So I'm mentioning it to you, and then they will go back to NICU. The thing to know about CDH is that the lung that's there is very abnormal. And so as you can imagine, that the gut has been pushed up into the generally left side of the chest, and that left side of that left lung has not developed normally. And so they are at significant risk of having a pulmonary basically having pulmonary hypertension from having a poor, very, very high pulmonary pressures, and they are at risk of having a pulmonary hypertensive crisis on NICU. So they can be very difficult to ventilate and very difficult to manage post-operatively because the lung is not normal. So it's not just a question of repairing the defect, it's actually managing the fact that they have a very abnormal lung, particularly on that side. So I'm assuming, Toby and Lauren, that there aren't any burning questions so far. If there are
no questions so far.
No questions so far. That's either good or bad. Or do we have any participants still?
Yeah,
thank you.
Good.
Thanks for the laugh. So going to continue with the theme of neonates. Collapsed neonates, I just think you should be aware of, because I wasn't really before I started doing paediatrics, that a collapsed neonate, generally it's a PICU problem rather than an anesthetic one, but neonates can collapse and present in early life, and there are 4 causes that I think you should be aware of. One of them is cardiac, and it generally presents at the closure of the duct arteriosus in the first few days of life. So if you're dependent on that duct for blood flow, and then that closes, you will then present as in a collapsed state. Metabolic, generally in the first few weeks of life, and that is, there's loads and loads of different causes, but it's not something you really come across in adult medicine, adult anesthesia, but it can present in early life. Non-accidental injury and sepsis, which does affect adults as well, but the first 3 are generally things that are fairly specific, unique to to babies and to pediatrics. So I think if you just remember those 4 things, I can imagine that coming up as a question. What because they're not things you would classically think about if you're just used to adult anesthesia. Moving on, we're still sticking with Paediatrics, that's right, because I'm doing a paediatric talk, but this is not necessarily a neonatal presentation. So this is an X-ray of a child, and the abnormality here is that you've got a loss of lung volume on the right side, and that in itself isn't enough to sort of know what it is. It could be a number of different things, but if you knew the history and it was a sudden onset after the child was playing with some beads, you would say that's likely to be an inhaled foreign body. You often can't see the foreign body on an X-ray, but you'll see the loss of volume. So it is relatively common, generally in the toddler age group. It generally presents, as far as hospital goes, it generally presents as not an absolute crisis, because they are catastrophic, and often they are children who don't survive even to coming to theatre. They might come to hospital, but if it's a complete obstruction and help doesn't arrive quickly, then it's pretty catastrophic. But often they do present to hospital with some degree of respiratory distress, and as I said, the foreign body is often not visible on an X-ray, but you need to have a high index of suspicion even if you don't have the history to go along with it. And the treatment for it is rigid bronchoscopy. And the principles of anesthesia for these cases are to keep the child spontaneously breathing throughout, so that you don't dislodge and worsen that foreign body. By giving positive pressure, you might push the foreign body further down, which might make it harder surgically, but in the worst case, make it into a complete obstruction, from a partial to a complete obstruction. So you maintain spontaneous ventilation. That's easiest done through an inhalation induction, even if you have IV access. You will then need to allow for bronchoscopy to take place while maintaining spontaneous ventilation. So you give local anesthetic to the vocal cords, and you maintain with sevoflurane, or increasingly now we're actually using propofol TIVA as a technique, but that's slightly harder to do. And then we give some steroids to cover for some airway edema, and the surgeons go in with that Stort's rigid bronchoscope that you can see on the right. We can plug our anesthetic circuit into a port on the right, and then they will retrieve the foreign body with a camera and a some other device, so whether that's a pair of forceps or a basket or something like that to get the foreign body out. Generally they don't receive antibiotics, and that's it. Inhaled foreign body. That is another sort of thing that you might need to recognize, I guess, and that is epiglottitis. So these are generally, well, fortunately, they're very uncommon now because of the hepatitis B vaccine, but they did used to present and can still present as a sort of young child, toddler or young child. They have significantly reduced in frequency because of the Hib vaccine. Most of the cases before were from hepatitis B. There are other bacteria that can cause epiglottitis. You might be asked about what the other big bacteria are, in which case you'd have to read about it because I can't remember. And they are classically children who present with inspiratory stridor. Toxic drooling is almost always related to something like epiglottitis. It might be related to a child who is who's got an inhaled foreign body, but generally speaking, if you see the word drooling, you've got to think epiglottitis. And they're slightly different to croup in that their croup is generally not a toxic child. They also have a cough, a barking cough, inspiratory stridor, but they're generally relatively well with it, whereas epiglottitis is a very unwell child. And the things, I think most people, whenever I ask about this in theatre and so on, most people sort of understand what the management is. And I think that's probably because it comes up in things like APLS. But the sort of general principle is don't worsen the condition of the child by increasing stress. So you've got to take a very pragmatic, practical approach to how you're going to manage this child. Normally, most of these children will not require urgent intubation, but they may do. And the principle at the start is to give some nebulized adrenaline to reduce the edema, oxygen to allow for that nebulized adrenaline to actually be nebulized, but they don't necessarily need oxygen beyond that. They're often not hypoxic. And if they do need intubation, generally speaking, we'd be doing an inhalation induction with the parent present, and then because we don't want to distress the child, you get IV access asleep, and only when you have got reasonable laryngoscopy would you then think about taking over ventilation, but often you intubate them deep and use a small ET tube because there is lots of airway edema.
Nick, very quickly,
yes.
We have a couple of questions that are coming through. Jessica has asked, can I just check? She asked, do you take inspiration and expiration x-rays? I think that's for the foreign body question, I suspect, as in for the foreign body slides you were using.
Very good question. I don't know I don't think you would need to, but I think that it's possible that that's written in a book, that you don't necessarily get a change in lung volume between inspiration and expiration. And I would have thought that you'd get a much more contrast between both sides if you are on inspiration, because one side would inflate and the other side wouldn't. But I don't know the answer to that. So thanks for the question, Jessica. I don't know the answer.
Okay, and we have one from Johnny who's asking, how do you deal with an apnea when using TIVA for a rigid bronchoscopy?
Yes. Okay, that's a very good question, and that's why it is hard to do. So the simple answer is that it depends on the situation that you're dealing with. But if you're doing rigid bronchoscopy and the child just stops breathing because they're so deep, then you may have to take over ventilation. And in practice, that can be done in two ways. You either remove the rigid bronchoscope and ventilate with a face mask, or if you're using that Stort's video, rigid bronchoscope, you can plug the end of the hole of the rigid bronchoscope and ventilate using the side ports, just to allow for some ventilation to take place, some oxygenation to take place. So the point is that you're trying to avoid that from happening, and you don't need very much ventilation to enable oxygenation for these cases, and you become quite tolerant of low SATs. So SATs in the sort of 80s and 90s is low 90s and 80s is quite common during a rigid bronchoscopy.
Brilliant. Those are the only questions so far.
Great. So we have got, are we going to go another 10 minutes? Is that right?
Yeah, that sounds great. As long as that's what we've got down for.
Yep. So collapsed septic child. So the question that has come up in the past: you're called to the emergency department to see a 2-year-old child who presents with a 4-hour history of high temperature and drowsiness. On examination, there is a prolonged capillary refill time and non-blanching rash. So I think you need to know the basic management of sepsis in a child. So the diagnosis is the signs that go along with it are a fever, a temperature of more than 38, altered level of consciousness, increased heart rate, reduced blood pressure, although that's a late sign, increased respiratory rate, early sign, high white cell count. But there are also lots of non-specific signs, and this is really important when you're talking about pediatrics, because children often don't present with that classic sort of syndrome of hypotension and so on. They just present with poor feeding, being irritable, vomiting, and that's just the unwell child. So how you would manage it, you would ask for senior support, and if you are particularly worried and you're in a regional district general, you would ask for, every region has its pediatric retrieval service, so you want to think about that early. You would, like with any emergency, give 100% oxygen to try and get IV access, and if you are unable to get IV access, you might want to think about intraosseous. You give fluid boluses of 10 to 20 mils per kilo. Don't worry too much about the amount of that. If you've got a very sick child, you want to be giving 20 mils per kilo. And you're aiming for normalizing some of those physiological parameters. And you're giving fluids fairly liberally at the start, and you may be needing to give large amounts, so something like 60 to 80 mils per kilo, 60 to 100 mils per kilo. APLS always talks about thinking about blood early. So after you've given 40 mils per kilo, you want to think that you might need some blood at some point. So think about cross-matching. You want to correct any hypoglycemia if there is one. Starting just your routine antibiotics as early as you can, as per your local guidelines. You might want to think about starting a vasopressor if the child is not responding well to fluid boluses, and often we start with dopamine, and that's just a pediatric thing. You don't need to know too much about the choice of vasopressors. And very unwell children, particularly children who have had lots of fluid, more than 60 mils per kilo, may well be heading for intubation and ventilation just for general management, and they will need to go to PICU. So I don't think you need to know very much more than that about collapsed septic child, but you do need to know the basics about management. And I think that would be fairly second nature to a lot of us. Cerebral palsy has come up, and here's an example of it. An 8-year-old child is scheduled for an elective right femoral osteotomy due to impending dislocation of the hip, and they have severe cerebral palsy. And the questions that were asked are, what is cerebral palsy? List the typical clinical features of CP and their associated anesthetic implications, and what are the specific issues in managing postoperative pain in this patient? Now, I think that's a bit unfair, actually, if you haven't done much peds, but in terms of the postoperative pain management. But CP is common, and you do need to know that it's a chronic neurological disorder of movement and posture caused by an injury to the developing brain. It is the commonest cause of childhood motor disability. And most of the time, these children have very often they are normal, intellectually normal children. They may not be, but they often are, but they have significant musculoskeletal abnormalities, and therefore it affects your musculoskeletal system, but it can also affect your respiratory system, and they often have feeding issues, so they're often PEG fed or NG or PEG fed. And the importance for us as anaesthetists are that there may be extrajunctional acetylcholine receptors, and you just need to be aware that although SUX is fine to use, Non-depolarizing muscle relaxants may have a shorter duration of action. In practice, that doesn't really matter to us, but it's one of those things that examiners might well want to know you're aware of. They've already got a lot of muscle spasticity and often pain associated with that, so they may be very sensitive to opioids. Communication can be challenging. Muscle spasms themselves can be painful perioperatively, and so they can be very difficult to manage perioperatively for big operations. And the question that was asked, if I go back, was what's the specific issues in managing postoperative pain? I would say that if you talked about that they have an increased sensitivity to opioids, muscle spasms can be painful, communication may be difficult, that you're covering most bases, and that you want to use a holistic multimodal approach to analgesia, that would be I think a good way of looking at that. Regional anesthetics are great, and outside of that, you want to use your multimodal approach, so paracetamol, ibuprofen, and using benzodiazepine for muscle spasms. This often comes up, not hands, but that is a single palmar crease that's associated with Down syndrome. And here's an example from gosh, that's 11 years ago. Gosh, 2011 doesn't feel that long ago to me. 5-year-old child with Down syndrome is scheduled for an adenotonsillectomy. Lists the cardiovascular, airway, respiratory, neurological problems that are associated with the syndrome. A very, very common question, very easy question for examiners to ask. Potential problems with induction and initial airway management. This could easily come up as a long case, and I think it's a very easy, you can imagine it's coming up because it's very common. And then the difficulties in postoperative pain management for a child with Down syndrome. So otherwise known as trisomy 21, and actually we should be using that much more than Down syndrome. It is the commonest congenital abnormality in paediatrics. It is a multi-system condition that affects a number of different systems, including airway. So there's a list of them there. I'm not going to go through them all because it's boring, and you can read this afterwards anywhere. But there are a number of different systems that it affects, and about half, 40% of them, have an associated cardiac anomaly, most of which don't need surgery or aren't that serious, but sometimes they are, and so they're obviously we see a lot of these children in a cardiac unit like ours. And as you are fully aware, that there is global intellectual impairment, particularly as the child gets older. There are a lot of anesthetic challenges that we need to be aware of, and the main ones are being potentially difficult airway and some specific airway considerations. They're particularly sensitive to opiates. They are associated with obstructive sleep apnea, and there might be communication and anxiety issues in addition to them being a child because of the trisomy 21. And postoperatively, they are at risk of airway obstruction more than an average child, and managing the pain and so on can be even more difficult because of communication issues. So I don't really think you need to know much more about that. I think you just need to know what the airway abnormalities are and that they might be a difficult airway that has a higher risk of obstruction. This is a joke slide. I was going to ask you what trisomy 1Q is, but because you can't say anything, it's going to really fall flat, so I'm not going to. But I did come across a patient who had that, and I just didn't know what it was, and pretended that I did. So this is a very common question from a few years ago. A 5-year-old boy presents with for a grommet insertion, and that he has nasal discharge. And basically, you need to be able to talk about the management of an upper respiratory tract infection for surgery or for anesthesia. So I think you just need to be able to know that upper respiratory tract infections for anyone who's got a child or seen a child is very common. The average child, interestingly, has up to 7 episodes of an URTI each year. Who would have known that? That most are viral, but the prodrome to a severe, potentially bacterial infection is often similar to a self-limiting viral infection, and that they it produces airway hyperreactivity that can persist for many weeks after it's gone, visibly gone. So we generally say up to 4 to 6 weeks, and you'd if you've had a significant upper respiratory tract infection, you want to avoid anesthesia for at least 2 weeks, but ideally 4 weeks. However, cancelling all children who have a URTI would have a significant economic and emotional economic impact for hospitals, and emotional burden for families, not for doctors. I don't mind cancelling them, but it's important just to have a bit of an idea about the history that goes along with URTIs, and the examination findings that are worrying for us. And there is no absolutes in this about when to cancel, but as a general rule, we would not want to anaesthetize a child for an operation that can be postponed if they have a productive cough, very purulent nasal discharge, a fever, because that's an objective sign, although actually I'm not too worried about a temperature. What I'm worried about is the respiratory sort of signs, because that's what I'm actually worried about for the child. I'm not too worried if they have a temperature, or if they're systemically unwell in the way of not being themselves, not eating, very lethargic. Examination findings, again, temperature objectively when they're in hospital, signs in the chest, or any other signs like reduced oxygen saturations or increased work of breathing, which you'd expect. Day surgery, I'm not sure you actually, I'm just going to rush through that slide. It's there for you to look at, because you might be asked the general principles of day surgery in children. And there are some general principles that you might need to know about, and they're there. So feel free to refer back to them. I think that Toby's going to distribute my slides and just have a look at them, because it has come up in the past. Social factors have actually come up in the past, which is interesting about day surgery. Consent. I'm aware that it is 7:45. I've got a few more slides. I mean, it's up to you guys. Is there a question, or do we want to keep going? Because there's just more slides, really. It's up to you, Toby.
Nick, we put it out to the group and said that you'd probably be about another 5-10 minutes. Just
okay. Well, I'll do another 5. I'm going to do another 5, and then I'm going to stop because
sure.
because
Sounds good.
I'm boring myself, so I can't imagine what it's like for you to actually listen to this. Consent is something that comes up occasionally in exams, and there are a number of rules. Basically, if you're over 18, the patient consents. If you're under 16, it's parental consent unless you're Gillett competent. And there's this weird grey area between 16 and 17 year olds and for children who are in care. I just think you need to be aware of that, and I'll talk about Gillett competence in a second. In terms of parental responsibility, again, this is something that might come up, and you just need to be aware that all mothers will have parental responsibility. Fathers who are married to that mother will automatically have it. If you're unmarried, and this is obviously increasingly common, that you do have parental responsibility if you are registered as the father on the birth certificate. And if you're not on the birth certificate, you can apply for it as a court order. It's not lost with divorce, and that's really the basic principles of it. Again, that's very easy because there are rules. They can ask about this in exams, and it is in your curriculum. Gillett competence, I think probably most people know what that is, so I'm not going to go into detail about that, but if you want to know what it is, it's there on the slides. And it is totally lawful for us to treat a child in an emergency in the absence of any consent in their best interest. Safeguarding is a topic that comes up both in adult and paediatrics, but it's much more common in paediatrics. And it is defined as the protection from maltreatment or neglect. And importantly, neglect is also there. So just don't forget about that. So it's not just, it's actually withholding certain aspects of care that a child is entitled to, not just maltreating them. And the basic duties of a doctor are to act in the best interest of the child, to be aware of the child's rights to be protected, to respect the rights of confidentiality, to contact the named doctor. That's the sort of phrase that we use in safeguarding. So every hospital has a named safeguarding doctor, and to make contact with that doctor or that team if you have any concerns about safeguarding. Be aware of your local child protection mechanisms. That's just one of those sort of phrases that will kind of encompass everything to do with child protection. I would be, if I came across a child that I was worried about, I would be aware of the local child protection mechanisms, and be aware of the rights of those people who have parental responsibility. So parents still do have some rights in this process, but if you're worried about a child's well-being and safety, then that will trump those rights initially. A few signs and symptoms of safeguarding. I'm not going to go into them mainly because they're quite depressing to read. If you have concerns, you would consult as a trainee, you would consult a senior colleague. If you're a senior colleague, you'd consent another senior colleague. You'd inform the duty paediatrician in your hospital and the safeguarding team, and they would take it from there, and then there would be a joint decision with the duty paediatrician of when and how to discuss it with the parents. And actually, just for your own interest, it's often much more open and frank than you might think. So that's my experience. There are a few random things from the APA that come out every now and again. One of them is codeine. One of them is difficult airway guidelines that is on the APA website and on the DAS website. Post-op nausea and vomiting, again, it's just there just to be aware of. Fluid management is another topic that has been very popular in the past, but I think increasingly less so because it's not so much of a problem. And it's basically, the principle is to use isotonic fluids, not to use hyponatremic fluids that used to be quite popular, like this one, which is a 5th normal saline, which is a very dilute saline with 5% glucose. And they've basically gone from hospital trusts in the last few years. So in summary, you will get a paediatric anesthetic question. Don't spend much time on neonatal stuff other than what I've said to you today. Have a look at some of the common emergencies that are in APLS and on the AAGBI list of guidelines, and think about some of the common comorbidities, some of which I've touched on today, that you might come across in district general level sort of anesthesia, and know a few common drug doses, but not loads.